Good morning, everyone. I call this meeting of the Public Accounts Committee to order. This morning we have with us Doctors Nova Scotia, and we'll be discussing funding and physician services. I'd like to remind everyone to place their phones on silent. We'll start with introductions, beginning with Mr. Farrell.
Good morning. I'm Terry Farrell, the MLA for Cumberland North.
Good morning. I'm Suzanne Lonis-Croft, MLA Lunenburg.
Chuck Porter, MLA Hants West.
Joachim Strong, Halifax Specto.
Ian Rankin, Timberley Prospect.
Good morning. Welcome. My name is Tim Houston. I'm the MLA for Pictou East.
Good morning. Nice to have you here. Dave Wilson, the MLA for Sackville-Cobequid.
I'm Alan McMaster, MLA for Inverness, and your chair. We have the Auditor General's office with us this morning.
Terry Spicer, Deputy Auditor General.
And we'll start with introductions beginning on the right here.
Andre Bernard, Chair of Doctors Nova Scotia and an academic anesthesiologist here in Halifax.
Nancy McCready-Williams, the CEO of Doctors Nova Scotia.
Heather Johnson, family doctor in Bridgewater, Nova Scotia, and board representative and chair of audit.
Good morning. Alana Patterson, Director of Physician Compensation and Practice Support with Doctors Nova Scotia.
And hi, I'm Kevin Chapman. I'm the Director of Finance Partnerships with Doctors Nova Scotia.
Thank you for being with us. Ms. McCready-Williams will allow you now to provide some opening comments.
Thank you very much. As I said, my name is Nancy McCready-Williams, CEO of Doctors Nova Scotia, the Provincial Medical Association and collective voice of physicians across the province. Thank you very much for this opportunity to have a chat with you this morning. And I just wanted to share that our president, Dr. Michelle Dow, is unfortunately out of the country and sends her regrets this morning. So as CEO, I am the sole employee of our Board of Directors of Doctors Nova Scotia, which is made up of physicians from across the province elected in a democratic process. And just for your information, our association is made up of 3,924 physicians here in Nova Scotia. So I will ask my colleagues, Drs. Johnson and Bernard, to introduce themselves and to present an opening statement.
Dr. Johnson?
Thank you, Nancy. We need look no further than the news to see ongoing discussion about physicians in Nova Scotia. Collaborative care, recruitment and retention, the shortage of family doctors, and gaps in service are just a few of the issues making headlines in our province today. Doctors Nova Scotia has a role to play in resolving each of these issues. In fact, the association has a legislative mandate that requires us to do much more than just negotiate contracts for physicians. We also work with our partners to promote health, prevent disease, and improve services for Nova Scotians. Doctors have solutions, and we welcome the opportunity to improve the system for our patients. Engaging individual physicians is important, and there is great value in engaging the profession as a whole through Doctors Nova Scotia. Long ago, physicians decided that the organization should be much more than just a union. Physicians see Doctors Nova Scotia's role as a means to influence policy, advocate on behalf of patients, and contribute to health system decision-making in a way that reflects the diversity of physicians' experiences and perspectives in the province. Individual physicians represent their unique and specialized interests and needs, but Doctors Nova Scotia understands the broader context in which health system change will take place. Doctors Nova Scotia can help decision-makers by providing perspective of all physicians. Both of these engagement methods are important. Over the years, Doctors Nova Scotia has worked closely with provincial governments and the health authorities to improve care for Nova Scotians. We value this collaborative relationship. It was the envy of other provincial and territorial medical associations. This collaboration was beneficial for patients, for physicians, for government, and the healthcare system overall. For example, Doctors Nova Scotia worked with partners to develop the province's 2012 Physician Resource Plan. We helped reduce medical seats in some specialties in order to increase seats in family medicine to allow more family doctors to be trained in Nova Scotia. We continue to be a part of the working group which considers a regularly updated physician resource plan and the implications of that for Nova Scotia. Based on recommendations from John Ross in 2012, we supported the move to collaborative emergency centers. Today, services are offered more consistently in communities that previously suffered closures. Doctors Nova Scotia worked with government on My Health NS, the personal health record. We see tremendous value in technology allowing patients timely access to safe, coordinated care.
I'm sorry, I must recognize you. I didn't catch she was finishing there. We'll go now with Dr. Bernard.
Thank you. In 2011, we extended the 2008 Master Agreement contract by 2 years when our province faced a significant fiscal challenge, a context that we know now as well. Extending the contract with smaller increases at that time saved the then NDP government $45 million. Over the years, we've worked with government and the Nova Scotia Health Authority to use physician contracts as a means to help incent the kind of services that Nova Scotians need and deserve. We've worked closely with the government and partners on a naloxone demonstration project to save the lives of people suffering from opioid overdose. In collaboration with the Nova Scotia College of Pharmacists, we developed a demonstration project in which physicians and pharmacists will collaborate to support the needs of patients with complex care needs. We championed health promotion policy by advocating for banning tanning beds and energy drinks for youth, supporting anti-smoking legislation, and supporting the health minister's legislation on e-cigarettes. And I'll say that some of the decisions and positions we've taken have made us unpopular with our members, but we persisted and we persist because they were the right decisions for our patients then and now, our profession as a whole, and for our province. And today our health system is experiencing challenges, and doctors have solutions and wish to contribute. We recently released 2 position papers. One outlines 11 recommendations for primary health care renewal to ensure Nova Scotians have better access to family doctors. The other paper offers recommendations for government and the Nova Scotia Health Authority and the IWK to ensure that physicians individually and collectively through Doctors Nova Scotia are involved in health system change. Nova Scotia is a small province, but together we can do great things. Working with Doctors Nova Scotia will yield the best outcome for the system and, above all, our patients. We welcome any questions you may have.
Thank you, Dr. Bernard. Mr. Houston, of the PC Caucus, you have 20 minutes.
Thank you, Mr. Chair. Thank you for the thoughtful opening comments. It seems to me that there are policies, government policies, that are impacting the ability to recruit doctors to the province. It also seems to me that there are policies that are impacting retention, and they're causing doctors to maybe not want to stay, or it seems like there's a vicious circle happening here. Now, both the opening comments, both Dr. Johnson and Dr. Bernard, stress that doctors have solutions. So I guess that was stressed, and working with Doctors Nova Scotia was stressed. So I guess I just asked like kind of a short question to begin with. Is anybody listening? Do you have the sense that, because that came through clearly in both the opening statements, does Doctors Nova Scotia feel like anyone is listening to the solutions that doctors are tabling?
Ms. McCready-Williams?
Thank you. Yes, I think people are listening. We value our relationship with our colleagues at the Nova Scotia Health Authority and the IWK and the Department of Health and Wellness. But we are going through a significant period of change in this province with standing up the One Health Authority and really Health Authority moving forward with a new primary care model. And so we thought it was important to make sure that the physician voice and the various perspectives around the implications of moving forward are heard. And we put it in the form of a position paper so that we could share that perspective easily with our partners. But I'd certainly like to turn it over to my colleagues because they can provide some firsthand experience in terms of practicing in Nova Scotia and what that experience has been like for the past couple of years.
I think that's open. I do have some questions about that, but I guess this, to me, I would say, as a new politician, relatively new politician, I've been in public accounts, and we've had the Department of Health here numerous times, and New Health Authority here numerous times, and I'm always taken aback by. It seems to me there's a clear line of accountability that's missing. And oftentimes witnesses come here and they seem to have little understanding of the businesses they're trying to run, and it just makes me wonder, how are these people managing a massive thing like the healthcare system, it kind of makes me nervous, because there is a relationship over time, no question, of political meddling in the system. Past and present governments for sure have contributed to that, but we have to kind of get past that. In terms of the experiences in the system today, I would like to ask maybe a question of Dr. Johnson about what's the sense in the profession of the impact on the mental health of the people working in the system. It's got to be, it's a heavy burden that's being carried by the people working in the system. As you said, you don't have to look past the news and some of these terribly depressing situations that we're hearing about. And I'm just trying to put myself in the stressful situations of the doctors, whether it's under pressure to take more patients, whether it's under pressure to provide treatment in an environment where we have a code census every day. I mean, it's just do you have concerns about the mental health of your colleagues?
Dr. Johnson?
We always have trouble when the work situation is challenging, and there are challenges. They're written in the paper. Most physicians in Nova Scotia cope as best they can and work as hard as they can to advocate for their patients. It is challenging, and mental health-wise, I don't have concerns, but I think that people get frustrated when they feel like over and over they advocate, and it's difficult to make change in a system that's this big.
So the burnout factor must be, do you have any stats on the burnout factor? Are doctors lasting as long, I don't know what's the proper way to phrase it, but are they practicing as long as they would have traditionally, or are you, as Doctors Nova Scotia, sensing any increase in the burnout rate of doctors?
Ms. McCready-Williams?
Yes, I think that there are a number of stressors in the system right now, and so we actually have worked with Acadia University to do a burnout survey and our GP Council to gather data on that, and when that's complete, we'll be analyzing that and understanding how we, through our professional support program, which is a program that we offer to physicians to provide supports, mental, physical, etc., what programs we need to put in place to help support physicians through this time. But I'm sure my colleagues could speak to their own personal experience working in the system.
Dr. Bernard.
As an anesthesiologist working at the QE2 Health Sciences Centre, you know, we're a massive institution that provides exemplary care in the spite of huge pressures, and we're hearing about that in the news nearly every day in the face of those pressures. And in the brief breaks, you know, I'm an anesthesiologist. I work in the OR. I have one patient at a time. My job is to look after providing life-saving care while they're having their procedures done and to deliver them through to their families at the end of it. In those moments of the day that I'm sitting in the coffee room and I'm listening to my colleagues in anesthesia speaking, what we recognize is that we see around us within the system, it's like a pressure cooker. And we are working harder than ever with limited resources and doing the best we can. One of the heartening things is, outside of the news headlines, what I see is we are providing exemplary care in spite of those circumstances. And part of, I think, what we have to offer, and part of the reason I think, through you, Mr. Chairs, to Mr. Houston, is that there's a resilience being trained among doctors today. And I think it's always been there, but there's been a clear focus. I'm an early career physician, and resilience and mental health has been focused for me. But there's implication for that, and that implication is new entering physicians, and I think Dr. Johnson could speak to this as well, are expecting practice changes and perhaps aren't willing to work the incredible hours that were expected of, you know, I grew up in Mabou. The doctors worked all the time in Inverness County, as our chair will know. That context is changing in response to the need to adapt and to be a practice that is resilient and yet work steadfastly for the health of Nova Scotians. So I think we are attuned to that more, and that is why I would argue and put forward that we're here to engage the system as Doctors Nova Scotia, as the collective of physicians in Nova Scotia, to build a system that is more robust for patients and that is more sensitive to not just doctors, but to the nurses and allied healthcare professionals, the pharmacists, all members that make up the healthcare team. because it's not just singly us. It's all of us trying to work together to make the system as effective as possible in spite of the stressors. And this fiscal context that we hear again, it's not just in Nova Scotia, we hear it in every province, there's no signals that it's going to get better, so we need to find ways of creating institutional resilience in spite of that.
Yeah, so that's helpful actually. So doctors are doing all they can, and they're speaking out on issues and asking for help on issues, and then we have situations like the $6 million that was withheld from doctors. I guess the first question is that I heard there was payments due to doctors under their contract that were normally paid in January. And I was hearing from doctors in March and April that said they still hadn't been paid. Do you know if those payments have been made as we speak now? Because I'm sure when you're working hard, you can't do your job, and then your boss is a little chintzy on your paycheck. It's not a great feeling. Do you know if they've been paid now?
Ms. McCready-Williams?
Yes, they have, and we really appreciate the Deputy Minister becoming involved in the issue and seeing that those payments were made very quickly.
Well, very kind of her, I guess, to fulfill the government's contractual obligations, but they fulfilled them in the next fiscal year, did they not? The payments went out in April, not January as they were due, right? Not February, not March.
The payments were late, yes.
Yeah, okay. But but you believe they've been made as we sit here today?
Yes,
Yeah,
yes,
okay.
we've been told they've been made.
And I do want to talk about, I do want to hear some of the solutions that you might have. Like, we have a doctor's shortage here, that's for sure. What is, we have a number of Canadians studying abroad. I've heard over 3,000 Canadians studying abroad. They could probably be part of the solution to the crisis we're feeling here, but there are probably some obstacles to those Canadians returning and practicing here. Are those obstacles something that we can overcome with good policy and good leadership?
Thank you. Yes, there are challenges in terms of recruitment and retention, and there are opportunities. So just to set the landscape, our physician resource plan that we developed with government states that we will, over the next 10 years, require approximately 1,000 physicians to be recruited, over 100 a year, half specialists, half family physicians. Just like every other industry, we have an aging workforce of physicians in this province. We have over 1,300 of our members, of our practicing members, are over the age of 50. Over 630 are over the age of 60. And so we know, based on the aging demographics, and I think most importantly, the population health needs of Nova Scotians, that we need to recruit. That's what our shared plan says, 100 a year for the next 10 years. And so there are opportunities to help with that. For example, there's a program called the Clinical Assessment for Practice program that was run by the College of Physicians and Surgeons that was discontinued. So right now it's very challenging for international medical graduates, you mentioned, to become practice assured and to be recruited into the province.
When was that program discontinued?
I believe that was discontinued last year, and I know that there are conversations happening between the college and the health authorities.
Were you surprised when it was discontinued?
It was, no, they served notice that it was going to be discontinued, but it needed to be replaced with something else. So the something else is in development. But in the meantime, there isn't a way to make sure that international medical graduates are practice
And what was that program called?
It's this Clinical Assessment for Practice program.
Okay. Is that like a mentor program?
It is partially a mentor program, and it's a program to assure that those who are trained abroad meet the standards in Nova Scotia and are integrated and welcomed into the province.
So that program was in existence for a long time?
For a number of years, through the College of Physicians and Surgeons.
And it was effective, but it could have been more effective, or why was it? What was the issue with it?
My understanding is that the college didn't see this as their mandate any longer, and that the Medical Council of Canada was going to show some leadership in working with the provinces to help find a replacement program. And as I understand it, that's in the works. But nonetheless, there's an opportunity from a recruitment retention to put something in place to assure practice readiness. Also opening up residency spots in our clerkship programs. So we have a family medicine residency program. We've got 3 sites that's very effective in training family medicine residents in rural areas. And we know that when family medicine residents train in rural areas, they're likely to stay in rural areas. So perhaps consideration of adding seats to the existing 3 sites, or even adding a new site in Nova Scotia to meet the need. But we do need to grow our own family physicians.
You've been asking for that? You've been asking for them to open up seats?
Yes, we would. So we've been asking to create a warm and welcoming environment in this province for physicians generally. And part of our primary care position statement is to let us work collaboratively with our partners to put in place a comprehensive recruitment and retention strategy for Nova Scotia. And this would be an element of that, certainly.
Okay. So how long have you been asking for them to open up more residency spots? Like, has that been a Doctors Nova Scotia position for a while?
So this has been a position that we've advocated in our position paper on primary care. We've been involved in many conversations because we are part of the Physician Resource Plan Working Group. We put the plan in place, and we're part of understanding the implications of the data when it's refreshed on a regular basis. And so moving residency spots around is something that we're part of. So for example, we were supportive of moving a couple of residency spots out of urology and plastic surgery to the new family medicine residency program in Yarmouth to ensure that met the need for increased number of family physicians trained in this province. So we're part of that conversation now, and so we've put that forward as an opportunity for the province.
Is that working group you reference, is that an active working group?
Yes, it is.
And who's in that working group?
It would be senior leader decision makers. So it would be representatives from the Health Authority, the IWK, Physician Services, other areas within Department of Health, and the medical school, of course.
Okay. So in terms of applications for credentialing, are you aware of, does the province get many applications for credentialing a year? Would you have a ballpark number of? So I'm trying to find out how many are getting rejected and what are the reasons they might be getting rejected.
So I do not have that data. That's not data that we would be privy to at Doctors Nova Scotia. I could ask my colleague whether you would have that data in terms of, we don't.
Okay, so do you have a sense of whether there's doctors that will come to Nova Scotia and live and work here, but there's obstacles to bringing them here, and I think you mentioned something about the international thing. That's probably, with that having been stopped last year, are we kind of just on hold right now for what's?
Well, that is on hold, but I don't think that's the full story. I think there's a piece of this that it talks about creating a climate that's warm and welcoming for physicians, and so I'd like to turn it. If you could turn it to my colleague,
Dr.
Andre,
Bernard,
to speak to that.
You know, in medical training, we start at the beginning of a journey that lasts between 6 and sometimes 15 years of formal medical training, let alone undergrad training. And I think it's important to understand that part of that story of what it means to be a medical student into a resident, into a early career physician, into a full practicing physician in this province is that we have choice at every step along the way. To become a specialist in Canada, in any province, you need to do residency. It's usually typically favored to do residency in a place other than where you did your initial training, although that's not required. There's kind of a tacit understanding that would be an asset if you were to return to your place of your home, if you will. As you move along the system, you have opportunities. For example, to become a specialist academic in Halifax within any of the specialties, and including family medicine, there's expected possibly to do something that brings added value, go away, come back. And I think at these sort of nexus points, that's a challenge for recruitment. And to go back to what Nancy McCready-Williams had mentioned, is that creating this welcoming environment and an infrastructure that is attractive. I'll tell you a story. It's a story from my best friend, who's a Prince Edward Islander, not a Nova Scotian. But he and his family have decided not to come back to this region because it's more attractive for them to raise their family in another place in this country. The remuneration profile is better, and the work-life balance is better. I think, that's the reality that we see, that people are having to make choices, that you get swept up. If I were to go to British Columbia to do a fellowship in something within anesthesia, opportunities come before these people like me that have choices. Some of us, the field of dreams phenomenon is something that I cite. If you build it, Nova Scotia, it's a wonderful place to live. I don't deny that. I grew up here. But we can't just sit on our hands and assume that people will come just because it's a nice place to live within the context that we have pressures that you alluded to before through you, Mr. Chair, as well as a remuneration context that makes us less favorable across the country. And those are sheer realities of what it means. So from a policy perspective, I think thinking about the remuneration framework within this province that enables recruitment and retention is important. And I would say the solution that has been put forward as the international medical graduate is one component of a very complex scene. We are recruiting and we are training physicians for Nova Scotia and for Canada within our 17 medical schools across the country. But again, to go back to the beginning, there is mobility and choice when you're done at any point in time.
Yeah, and in the face of the competing factors and jurisdictions and maybe better pay and all these types of issues that go into deciding where a person lives and works, my sense is that doctors, quite frankly, just don't feel respected in this province at the moment on a lot of different levels, whether it's the pay, whether it's the pressure cooker that's constant every single day due to staffing issues. So I guess I'm running out of time.
You have 30 seconds remaining.
Okay, well, I'll defer my 30 seconds, and maybe I'll come back to Ms. Patterson in the second round and ask what she's hearing from the practices that she's supporting, but we'll save that one.
Thank you. We'll move to Mr. Wilson of the NDP Caucus.
Thank you, Mr. Chair, and thank you again for coming and accepting the invitation. I know we were not scheduled to have a meeting today, and I know especially this issue is extremely important to Nova Scotians, and no secret, we're on the eve of an election, and healthcare, in my opinion, is still the #1 issue that Nova Scotians face and are concerned with. So, thank you for accepting the short notice and for coming here today. There has been a lot of talk around physician resources, recruitment. How are Nova Scotians gaining access to care in our province? And one of the things I know over the last number of years, and as a former paramedic, I understand completely that yes, we need to be ready for those emergency cases and when trauma and accidents happen. And I have to say, when Nova Scotians are deathly sick or ill or injured, they get amazing care here in our province. When we go down the level, I guess, of urgency, and not that it's less urgent to be able to get in to see your doctor, but it has a domino effect. And I know how important it is for access to primary care, access to a family doctor that can alleviate, visits to ERs, use of the 911 system or the EHS system. So engaging with your organization is so important. You indicated you represent just over 3,900 physicians. Could you just give us a quick snapshot of the types of physicians that are there? I know a physician is a physician. Some people get all upset when you say a nurse, a physician's a physician, a paramedic, ambulance driver. We get upset at terms. But what could you quickly tell us the demographic of the physicians that you represent?
Ms. McCready-Williams.
Thank you. Of the roughly 3,900 members, 2,400 are practicing members in this province, and we have almost 400 of our members are retired, but still actively involved in the association. We have almost 350 students, and we have almost 600 residents. All of those make up our membership.
So when a resident, just quickly, when a medical student becomes a resident, resident, is that what you mean, residency?
Yeah, they're still in their formal training.
Excellent.
Exactly.
Okay. Thank you. So I see that as an important resource. So I know in my time, behind the big table, I guess, if you want to call it, I engaged in dialogue with Doctors Nova Scotia. I believe my colleague before me, Maureen MacDonald, ensured that I recognize the importance to engaging with Doctors Nova Scotia, meeting regularly. I think it was monthly is how we set it up. Is that continuing with the current government? Are you engaging with the department, the deputy minister, so that those discussions can happen?
Williams?
Yes, certainly the President and I, Dr. Michelle Dow and I meet monthly with the Minister, and I meet monthly as well with the Deputy Minister. We don't have as much communication with our colleagues in physician services and with the NSHA as much as we used to, but we're working on that, and we're open to collaboration and continuing to work together. We can do more than we can working in isolation.
Yeah, and that's part of the area of concern that I've seen over the last little while. Is it the fact that some of those who are in charge of physician services have left the Department of Health? I know they, well, in my word, gutted many of the higher senior positions there, and they're somewheres out there in the new health authority. So did you find a difference when those positions were eliminated in the Department of Health, the ability to engage and bring concerns to the forefront, to people who can maybe address those issues?
So certainly some people left, but others came. So I don't think that's the issue. I think, quite frankly, that, and this is not something that is surprising, because we've had open discussions with Department of Health and Physician Service specifically about this, but the negotiations process was a long and difficult one. And when you work collaboratively with people and then you're across the table from one another, it's not easy. And it's not easy on relationships. And so we're in the rebuilding process, and we're looking for, that to get back to sort of a mutual collaborative framework. And I'm hopeful that we will find ourselves there. And so that's essentially our situation.
Is that a result of the way the government approached those negotiations? Because it's not a secret. The government has taken a hard line from day one with unions and with groups that they've been negotiating with. I know that the Doctors Nova Scotia signed the agreement. Was there at any time any indication what would happen if you didn't sign it? Did you feel pressured to sign it? Did your members feel any pressure that they needed to agree to the master agreement and move on?
So it was a difficult situation all around. I mean, negotiations are not pretty, and we worked very closely with our members and with our negotiating teams, and with government and their negotiating team. And we believe that in the current fiscal climate, we got the best possible deal for our members, and we endorsed it. Our board endorsed it, and we went to our membership and recommended it. It was the absolute best possible outcome in the fiscal environment. That's not surprising to anyone. That doesn't mean that our members are happy with it, but they understood, I believe, and they had confidence in us when we told them this is what it is, and we believe that time to move on, time to work to improve the system, the health system for everyone. Time to go back to doing what we do best, and that's caring for Nova Scotians.
Thank you for that, and I understand the difficult position you were in. We understand the current government and their appetite to move forward with the amalgamation of the District Health Authority. That has been their flagship, I guess, commitment that they made to Nova Scotians, amongst some others, like a doctor for every Nova Scotian, and I'll get to that in a few minutes. But with the amalgamated district health authority, I know that some of the concerns are the loss of the ability to make sure that in certain communities and areas of the province that their voices aren't being heard. And when I read through your recent position paper, physician recommendations to improve primary care in Nova Scotia, what stood out to me is it seems like the engagement with the physicians, primary care physicians, family physicians, maybe doctors in Nova Scotia, that physicians are feeling that they're not part of the discussion of the new approach or the new model that the government continues to beat the drum on, and that's the collaborative clinic model. We know they've made a number of decisions, and I think some of them prematurely, and when I look through your recommendations, you address some of them. Do you feel that that's the feeling out there? Do you feel that that government hasn't done a good enough job engaging with Doctors Nova Scotia, with frontline family physicians to move towards maybe changing the model of primary care delivery in the province?
Ms. McCready-Williams.
So government has admitted that, and the health authority in particular has admitted that engagement of physicians through the creation of the new health authority and then moving forward to develop a new primary care framework was not as high as it should have been. I think that's we've talked about that publicly, and I am hopeful that that the health authority in particular sees the importance of it. I spoke at a panel discussion of senior physician leaders hosted by the health authority last week around physician engagement, and I was very hopeful in terms of what I heard about the need for the health authority and the senior leadership of the health authority saying it's time to further engage the physician community, because certainly that's what our members want. They want to be part of the solution. There's been huge change in this province in the healthcare system, and it's change management 101 to engage those impacted by the change in understanding how it impacts them and giving them a voice to help shape it. And so physician engagement and engagement of Doctors Nova Scotia, because we can bring the collective perspective to bear, critically important moving forward.
Have they responded yet to that discussion paper? I know there's I think 11 recommendations in it. I know when we asked the deputy minister, it was I think the day before, day of the release. So I was okay with, we're going to look at it, but that was. I'm trying to think of the date now. 3 weeks, maybe 3 weeks ago. Have you had any response from the government on your position paper, and specifically around the recommendations? Because there are some good ones there that will, I think, assist moving the province forward.
Through the chair. Yes, I got a call that day from Dr. Lynn Harrigan, the day we released the paper, who's VP of Medicine for the Health Authority, congratulating us on the paper and stating that it aligned with the Health Authority's vision of primary care moving forward. We've also been asked to co-chair a working group on a new primary care payment model. We've put that suggestion forward. Let's get at that now to work through that. Before we get to the next negotiations table, let's be thoughtful, take the time it needs to do what's best for Nova Scotia. So I am hopeful that we've prompted some stimulating discussion and that we'll be moving things forward.
Yeah, and it's unfortunate, in my opinion, that it took Doctors Nova Scotia to release a position paper to have the new super board or health authority ask you to be on a working group to hopefully improve access to family physicians or primary care. It's extremely frustrating seeing that timeline that has passed without the engagement with Doctors Nova Scotia. I've been hearing interesting since the government took over. Of course, one of their other areas in healthcare that they commitments that they made was a doctor for every Nova Scotian, and often for years that was a rural issue. I have to admit, being a MLA from the suburbs, I never received that many calls for people without having access to a physician, family physician. But over the last 2.5, 3 years, definitely I've been called, and it's not just a rural issue, it's all across the province. One of the things we've seen was a recent decision to change the policy around credentialing, or I use the access to licensing and that, but they say it's credentialing or privileges that they're limiting. So have you had, are physicians being asked or forced into buying into the collaborative clinic model, or having to move to that type of a model here in the province? Are you hearing from members that's being that's the process that's being unfolded now or taking place?
So I think the privileging question and the collaborative care question are two different ones, if I could just answer them separately. Sure. So the privileging process, is new to the province since the new health authority was stood up. And the question is, the question we would have a concern with is how it's being done, not necessarily that it's being done. In fairness, Doctors Nova Scotia participated in helping to shape the bylaws. Government put forward that, in fact, this was going to be a requirement of receiving lab and DI results. So if you weren't, a physician wasn't privileged and they wanted that kind of access to test results, they would need to be privileged. So we helped to shape the bylaws. Sometimes we're concerned, and we hear from our members, that how those decisions are made is not clear, and that there isn't as much flexibility in the privileging discussion with physicians as we would like there to be. So that would be sort of a
we know in recent past history, I guess recent maybe, places like British Columbia, the government tried to, in my view, impose restrictions on physicians and their ability to move about the province. They were taken to court. The government lost it. Is that an avenue, or are you familiar with that? Because the deputy wasn't familiar with the court case, even though she came from Alberta, the province right next door. Are you familiar with that court case and the decision? And are your members concerned that potentially the government's doing something that they really don't have the authority to do, and that's restrict physicians' ability to work in the province in the communities that they choose to work in?
So, yes, I'm absolutely familiar with the BC situation, and Doctors Nova Scotia took a position that in terms of restricting billing numbers, we would be absolutely opposed to that. However, we did help to shape the privileging process, but how that's done is what's been at issue. So, for example, most of physicians in Nova Scotia who worked outside of HRM, of the urban core, were already privileged. They were seeing patients in hospitals. Many family physicians in the Halifax-Dartmouth area, Bedford Fall River, were not privileged. And so when the new health authority was stood up, there was a transition to bring those physicians in. But the privileging discussion also comes up vis-a-vis recruitment retention, because in the recruitment for new physicians, the health authority appears to be fairly rigid in applying whatever guidelines it has around making decisions about who can practice where, and how physicians would spend their time. And so that has created a challenge in terms of recruiting for some really key positions. Like for right now, we have 118 positions on the NSHA website, physician vacancies that need to be filled. And as my colleague, Dr. Bernard, said, the younger demographic coming in doesn't want to take over a patient load of 4,000 cases. It's impossible for them to deliver good patient care in that environment as a young career physician. So for an example of flexibility, what I'm talking about is it's not a one-for-one situation that one physician leaves and another physician replaces them, particularly if the demographics are different. What we would love to explore is what they've done in the province in the surgical area, where there's a program where physicians who are nearing retirement, surgical specialists, particularly in rural communities, will start to sort of wean off their caseload and bring new surgeons on. And there will be sort of a weaning off and a ramping up at the same time. And what's most important is a mentorship opportunity, so that young early career physician or surgeon family, whatever specialty, has an opportunity to become familiar with the caseload, and most importantly, have a mentorship opportunity with that retiring physician. So if you're just looking at sheer numbers of how many physicians can be privileged, that kind of flexibility, we would suggest, would go a long way to creating that warm and welcoming environment in the province, and it shouldn't be a burden in terms of the sheer dollars. It really, you're creating an opportunity for sort of a handoff and a growing and a mentoring opportunity.
Would you agree that that burden is in place now? Because that's what I'm hearing from physicians in my area that are looking at trying to retire for one, but trying to recruit physicians to come in and support them in their practice, especially when their practices are growing, and they're getting called every day from patients who don't have a family physician. Is there a burden now, and is that what I read from your discussion paper, position paper, is that the government has made decisions like what you just spoke about prematurely before physicians transition? So I know I only have a minute. Are you aware of any of your members being forced to move into these new collaborative clinics, are being told that they will no longer have a license unless they practice here? Are you aware of any of those cases happening to your members or in Nova Scotia?
I'm going to turn that over to my colleague, Alana Patterson, if I may, through the chair.
Ms. Patterson?
To answer that question.
Thank you, Mr. Chair. I don't, and I'm going to look to Kevin as well in case he has insights here. I don't think that we're aware of any current members who are being given that stark a choice. I think for incoming potential new recruits to the province, the situation is a little bit different, and I think that their choices might be a little more limited than we would like to see. But I can't sit here and give you specific examples of that. I think that's our sense. Is that fair?
Thank you, Mr. Wilson. We'll move now to the Liberal Caucus. Mr. Rankin.
Thank you, Mr. Chair, and I want to thank you for coming in today on such short notice for an important topic today. Maybe I'll start with articulating the mandate of Doctors Nova Scotia. I know you mentioned that it's more than just negotiating for your members, but it is an important part of your mandate to look after the economic interests of the members. If you could maybe talking about recruitment, because that's the topic today, and trying to work together cooperatively to attract doctors to the province, and obviously there's some negativity in the media and from opposition members about compensation and other things, and I know compensation seems to be dominating the discussion today, but I think it's also good to talk about a patient-centered model. So I guess a couple questions, if you want to articulate within your mandate, what have you been doing to recruit doctors to Nova Scotia, or to help government recruit doctors to Nova Scotia?
Ms. McCready-Williams.
Certainly, what we've said to government is let's develop together a comprehensive recruitment and retention strategy, because there's things that we can do as an association. We have a robust benefit plan as part of our master agreement that's an attractor to Nova Scotia for physicians. There's things that, so for example, there's things we can do, there's things that the Health Authority can do, there's things that the Department of Health can do. And so, our offer is let's work together. For example, last week, I know my colleague Kevin Chapman met at the invitation of the Health Authority, which was great, with all the physician recruiters in the province, to get a set, so that they asked the question, what is it the Doctors Nova Scotia can do? And what services do you offer that will attract physicians to this province? And so we had that conversation, and again, together, I think we can create that warm and welcoming environment.
So you do see that as within your mandate to work together to recruit doctors to Nova Scotia?
Yeah, we would welcome that.
Okay. So let's talk about the master agreement that you said that you cited there, and 80% of your members accepted that less than a year ago, and 87% of your members accepted the AFP contract. So there was support there. And when I read through the papers, the position papers that you recently released, it seemed to me that you've took exception to some of the things that are in that contract. And, you know, when you're talking about the transition to collaborative care, and there's also more accountability measures in that contract. There's also the requirement to focus on the patients. So weren't these issues discussed during the negotiations when this agreement was decided upon? Or I noticed compensation was mentioned quite a bit in the position paper. So was it the compensation that you have the biggest, I guess, disagreement with in terms of that agreement?
I would say that our members, it wasn't really about compensation, because I think our members appreciate the challenging fiscal realities of this province. And so the fact that Nova Scotians, regardless of which test you use under CAI data, there's 4 different methodologies, physicians in Nova Scotia are at or near the lowest in Canada paid. That's a fact. That's in the data that you shared with us in terms of your opening materials. And so to move that up is expensive, and our members appreciate the challenging fiscal realities of this province. So it was not the money per se. There were some physicians who weren't happy. Family physicians in general, and I'm not going to say that they were happy, but they appreciated that it was the best that was on offer. But I think what physicians were most disappointed, certainly when we went around the province, the challenges, perhaps the lack of an opportunity, was around some of the innovative things we'd hoped to be able to see in this contract, and I think it just wasn't the right time. And things like a new payment model that would support a collaborative practice. That was something that we had hoped to see, but again, not good timing. And I'm really pleased that we're able to have those conversations outside of a negotiations context with our partners. And now that it's very clear what the NSHA's vision is for collaborative care in the province, I think those conversations will happen now. Other innovative things like non-face-to-face care. We didn't go as far as we'd like to see in terms of the opportunity brought by My Health NS, the personal health record, but again, those are conversations for a future time, and we're hopeful that will move forward.
Okay, so you represent 3,900 some physicians, and I see the breakdown in terms of different cohorts, but what is the breakdown on full-time and part-time within that 3,900?
That's something that we do not, we don't track the part-time numbers.
Okay, and in terms of physicians per capita, which is probably a good measure to see relative to the other bigger provinces, where do we stand in, against the other provinces per 100,000? Do you have those metrics?
Yes, so there's been a lot of press around numbers of physicians. How many do we need? How many do we have? And so what we know, again, this is CAI data, that we have a very high number of physicians per capita. And so there's lots of physicians in the province. And how do you square the circle then of why are there wait lists? Why can't people find a family doctor? And so I think it's a bit of a red herring, the number of physicians, because we would expect there to be more physicians in Nova Scotia than in other jurisdictions, certainly in Atlantic Canada, because number one, we're a teaching province, so we have a medical school here, and our physicians not only deliver care, but they also train the next generation of physicians. Because of the QE2 Health Sciences Centre, we also have a research arm so our physicians are doing research as well as delivering clinical service. And I think most important to remember is that our physicians, certainly at the QE2 Health Sciences Centre and the IWK, they serve all of Atlantic Canada. So their patients are not just Nova Scotians. But regardless of how many physicians are in the province, what we know to be true is that's already factored into the physician resource plan. We know those numbers, and still with those numbers, given the demographic changes in the physician community that I shared with you, we need 1,000 more physicians in Nova Scotia over the next 10 years. So recruitment, retention.
Look like fiscally to the province to try to take in 1,000 more physicians?
So remember, many of those are just replacements.
Yeah.
this aging demographic we have, so 1,300 of our 2,400 practicing physicians are over the age of 50. And so we know that we need to replace those who are practicing now and who are set to retire. And there's a small number in the physician resource plan that is there to deal with what we believe and what governments believes is going to be an increase in burden of illness, because we're an aging demographic in this province.
Yeah,
and
that's an important point, the aging demographic. So do you have a role on promoting health wellness, and what is Doctors Nova Scotia doing? Did you put anything into the efforts on Choosing Wisely Canada campaign? And can you articulate what you'd submitted to that campaign in order to, because we do have to focus on a healthy society and not just treating sick patients, right? So I would think that's within your mandate. Maybe you can articulate how you helped us with that.
Yeah, so absolutely, we have a health promotion mandate, and I think my colleagues in opening comments talked about some of those initiatives. Just before I turn it over to, through the chair, to my colleague Kevin Chapman, who's been very involved in the Choosing Wisely initiative, I just want to remind everyone here that we have embraced the Kids Run Club for the last over 10 years now. And as a result of a program that we have in the school system in Nova Scotia, we have over 17,000 young children running every year in over 300 schools in this province. And so physicians are very, very proud of that program, and they firmly believe that that kind of being leaders in health promotion will address some of the issues that they see in their patients on an ongoing basis. So health promotion is very much part of our mandate. And through the chair, if I could turn it to my colleague.
So I just want to go back to the paper. So you're pretty clear that you want doctors to be able to determine where and how they want to work. Can you articulate how that benefits patients? And it's basically one of the only professions where the government would say, step back and say, you're using taxpayer money, you choose wherever you want to go, regardless of demographics. And do you believe that there should be an incentive for doctors to go into rural communities?
So I just want to clarify, I actually didn't say what you summarized me to have said. We didn't say that physicians should be able to practice wherever they want to. We helped to shape the bylaws that govern the privileging process. So we appreciate that there should be a population-based need for physicians to be practicing in any particular area. It's the how it's being done that we're suggesting should be more flexible. Physicians are business owners. They're small business owners for the most part. And so they're pretty savvy about where they can set up a practice and in order to be able to pay the bills. I mean, they are pretty savvy that way, and supply and demand will eventually be a deterrent if there are too many physicians in one particular area. So you know, we appreciate the privileging process, and we appreciate the need for that from a patient care perspective, making sure that physicians are located where there is our patient care needs. And what we're suggesting is that the health authority and the government need to respect that physicians are small business owners and to work with them with some flexibility in the recruitment and retention process.
Right. So in terms of the international program, you think that's a good program if someone has signed and they've gone to a different country, that they're going to an underserviced area? You think that's a positive thing, that they'll be placed in an underserviced area in rural Nova Scotia rather than if they wanted to choose HRM?
Yeah, no, we have no problem with the IMG program.
And so, also mentioned in your papers, you suggest that doctors should roster their patients. Does that mean having a certain number of patients to clarify per physician?
Yes, so we believe that every Nova Scotian should have access to a family physician as part of a primary care team. And so there would be a rostering of patients to that team, and the blended payment model would support how that care is delivered and who delivers what kind of care as between the various specialties.
So have you calculated exactly how many physicians we would require for a population of 1 million to meet that need?
So that's already factored into the physician resource plan. There's a proxy there for collaborative care. And so even with collaborative care baked into the plan, it says we need to replace those who are going to retire over the coming years to the tune of 100 a year for the next 10 years.
Yeah, and that challenge is across the country, replacing doctors, right? So
Yes.
basically all provinces have this challenge of recruitment in the country. Yeah. So can you explain in your document when you say the pressures on the physicians in Nova Scotia from being an Atlantic centre, I don't quite understand how that's congruent with general physicians, as they're typically based within a community, and do they not see, by and large, just people that are from the community and not very limited people from outside of the province? I'm not talking about the hospitals, I'm talking about the family physicians.
So the numbers in the physician resource plan would reflect community-based family physicians and specialists, and as well our clinical academic physicians based at the IWK and the QE2 Health Sciences Center. So it's those specialists, and there's about 630 of them in our active membership who serve not just Nova Scotians, but as well.
Yeah, so that's the
those
acute
from,
care system
yes.
that Atlantic Canadians use, the IWK and stuff like that. But in terms of the family physicians, there's not a drain from Atlantic Canada, people coming to use our family physicians, right?
Correct.
Okay, just wanted to clarify that. So the concern in the media about Northside being impacted by the signed agreement. The Deputy Minister and the CEO of the NSHA, they were saying that as a result of the negotiations to remove inconsistency in how physicians are paid throughout the province, this is an agreement again that you've agreed to. The consultations took place over 5 months involving the NSHA, Department of Health. Total volume of patients seen at the affected sites is comparable, ranging from 25 to 27 patients per 10-hour shift. The Department of Health and Wellness has discussed with Northside site-led physician ways to manage the implementation of changes to minimize the negative impact. So I'm not understanding the agreement was made and how come there's such negative feedback on that.
So I'm just going to introduce the topic, and then through the chair, if you might, I'll turn it over to my colleague, Alana. So absolutely, we were brought in once the agreement had been reached with the chiefs of emergency departments across the province and with the NSHA, and we all understood a certain set of facts. And then and so they brought us in, terrific. We signed off on it, absolutely. And then, as I understand the facts, there was a misunderstanding about a particular assumption around those facts that might have had an unintended impact. So I'm just going to turn it over to my colleague Alana to speak to that, if through the chair.
Ms. Patterson?
Thank you, Mr. Chair. Yes, so as Nancy has said, the Department of Health, the Health Authority, worked, as we understand it, with emergency department chiefs across the province in an effort to look to standardize emergency department rates, hourly rates, across the province for emergency departments of comparable patient volumes and patient acuity levels, or patient complexity, if you will. The exercise was intended to reduce the occurrence of ED closures by creating consistency across like facilities. And so in principle, we would of course support that. We were brought in as that analysis had been concluded. We reviewed the data. We gave some consideration to the physicians who had been consulted, and we were comfortable that the principles were sound, the analysis looked sound, and appropriate physicians had been engaged. And so we brought that to our board of directors, and they did indeed approve, as you've suggested, the approach that was recommended. What's come to light since, and I think it's news not just to DNS, but to the Department of Health and to the Health Authority as well, is that the implications for Northside might not be quite what was intended. So appreciate that. As I said, the exercise, as we understand it, was intended to reduce the occurrence of ED closures, and the risk now, as we're hearing it from Northside, is that in the case of Northside, they may be far more challenged in trying to fill shifts in that emergency department than previous to the change. And so with that in mind, the Health Authority was, we believe, fairly responsive and indicated that they would delay the intended rate reduction for Northside in order to give this some further consideration. We have been watching the committee's deliberations in recent weeks, and so we were pleased to hear Deputy Minister Denise Perrette from the Department of Health a few weeks ago when she indicated that she was prepared to revisit the implications for Northside, and so we look forward to being engaged in those discussions. in order to ensure that the objectives are in fact met by the final decisions.
Okay, thank you. I'd just like to end with, to try to get some of your thoughts around alternate care. So nurse practitioners comes to mind, top of the list, but there's obviously other ones. So you're supportive of collaborative care. That's your official statement. So do you have any issues with nurse practitioners getting more involved in the hospital level or other types of work, signing off when patients can be released from hospitals or any of those? And I recognize that you do represent doctors, and there's an economic component to that. But can you say that you support alternate system delivery?
Ms. McCready-Williams?
Certainly, we support and our members support working with allied health professionals, including nurse practitioners. In fact, we hosted a webinar last month for physicians who are working with nurse practitioners now, have had a wonderful working experience with them in collaborative practices now, because collaborative practices have been around for a long time in Nova Scotia. There's great examples, like in Clare, of collaborative practices where nurse practitioners and other allied health professionals like family practice nurses, et cetera, have been part of that team. So we hosted a webinar giving physicians who haven't had that opportunity to work with a nurse practitioner an opportunity to sit down with the physician and their partner, the nurse practitioner, and have a conversation about what works well, what are the challenges, in anticipation that more of these practices will be supported moving forward.
And in that same vein, if I may, Mr. Chair, do you think it's a positive thing that we're moving towards a lower percentage of the fee-for-service model? I think Nova Scotia is, the chart I have is it's among the lowest. Other than Ontario and Alberta, we have been able to decrease the amount of fee-for-service payment model. Do you think that that's a positive trend?
So payment models are a policy tool because how one pays physicians can have an impact on that physician's behavior and the type of care that's delivered to a patient. And so it's why we're recommending for a collaborative practice model that there be a blended tool where we have, where there's a part of is a fee for service to ensure appropriate volumes, and then part to recognize that physicians, as patients have more complex needs, need to spend more time with physicians that require that. And that's really not taken care of in a fee-for-service model. But we've had great examples of alternate payment mechanisms, like our academic funding plans that compensate physicians for not just clinical care, but for time spent teaching other physicians at the medical school and for doing research.
Thank you. We'll now move back to Mr. Houston of the PC Caucus for 14 minutes.
Thank you, Mr. Chair. I had indicated I was going to start with Ms. Patterson, but I think maybe I'll start with Mr. Chapman, just listening to the discussion here. When I have a question about the federal transfer payments, I mean, Canadians all across the country are reading about the tragic situation of Mr. Webb, in his stay in the hospital. And Nova Scotia Health Authority's officials are continuing to reassure us that very sick people are getting the care they need. But clearly that's not always the case, and we heard about the pressure cooker environment in some of these hospitals with the code census and stuff. But we need more resources to solve shortages in long-term care, in mental health, and of course in primary care. So with the new federal transfer agreement, we're going to get less money. Are you concerned about how we're going to provide the services we need under the new agreement?
Mr. Chapman?
So thanks for the question. So we're going to get less money than we otherwise would have, but we will still get more funding. And I think having targeted funding for mental health and for home care are areas of needs, and certainly Dr. Johnson, I think, would see that. The situation with Mr. Webb, as you talked about, obviously was an incredibly tragic and unfortunate situation. But I think it speaks to the kinds of things that Dr. Bernard talked about in terms of the stressors on the system. And we need to be able to do things to relieve some of those stressors, certainly alternative levels of care, having patients who don't need to be in a hospital. That's CAPE, which is the Canadian Association of Emergency Physicians, has released a position paper on ED blocking And certainly one of the big things they've talked about is alternative level of care patients and being able to have those patients out of the hospital. So, a focus on home care is key. One of the things CAPE has talked about, interestingly, which we're talking about, is a robust primary care strategy. So it really is about reducing those kinds of pressures on the acute care system by having individuals treated where they are most appropriately treated, so that if somebody does need to get to the hospital, if you're a level 1 or 2 CTAS patient, and I believe that the quote with Mr. Webb was he was the sickest person that they had seen that evening, he can get the care he needs in a timely manner. So I think having some directed and focused funding around mental health that would help perhaps family physicians. We had a practice support program, for example, that allowed family physicians to improve their skills in managing patients with mental health and addiction. So if we can look at those kinds of things and improve our primary care framework and our sort of secondary care, I think there's a great opportunity for reducing or removing some of the stress on the acute care system.
Yeah, so have you seen is there a plan to how we're going to pay for the things that we need? Because certainly on Christmas Eve or whenever it was, when the government announced the new funding arrangement, it was heralded as a big success, particularly around mental health. Now colleague and I, Mr. Wilson, have been asking questions in here about what that actually means, and the details aren't worked out. Nobody actually knows what it means. Doesn't sound like it's much in the grand scheme of things. So when I know that the province, I'm going to say, kind of catered on the negotiations with the federal government and walked away with less and tried to make it sound like they got more, once we started asking, did they really get more, is not much substance to the answers. So I'm deeply concerned about how we're going to pay for the things that we need. And I guess in your role with Doctors Nova Scotia, do you have any more comfort than I do? Like, is the department kind of sitting down with you and saying, well, here's our needs and here's our plan and here's how it's going to work? Do those discussions happen? Maybe as part of one of the working groups or something?
So a couple of things. We've worked with Canadian Medical Association, who has been in touch with and speaking with the federal government, because these are federal funds, around what parameters, if any, the federal government might place on the use of those funds. So we're working through the Canadian Medical Association on that perspective. One of the benefits I think that we have in Nova Scotia, particularly with the mental health, is we have the Together We Can strategy, which was developed and provides a guideline for investments in mental health and addictions services. And again, one of the programs that is near and dear to us is the BC Practice Support Mental Health Program. So while we don't know for certain how the funding will be spent and what those, as you've mentioned, what those constraints might be.
Or how much it is.
Or how much it is.
I think you kind of answered my question when you said you're trying to work with the Canadian Federation, right, as opposed to, because our own minister signed it, and I guess there's nothing coming your way from the Department of Health as to what might have been signed, because they don't probably know what they signed either, right? So you're having to go to somebody. You're having to go to somebody else to try and find out what your government agreed to. Is that the long and short of it?
What the parameters might be from the federal perspective on what the targeted funding through the CHT is, and then what opportunities that then might present to us.
So the deal's been signed, but maybe it's been signed. I don't even know if they said it. First they said it was an agreement, then they said maybe not an agreement, it's going to be legislation or something. But anyways, okay, so I'm concerned about how we're going to pay for what we need. Everyone here is probably shares that same concern. I do want to I want to talk about the reference to the 118 vacancies. I'm not sure who's the best person to answer it, but we heard here this morning about new doctors are being kind of pushed into collaborative centers. Maybe that's a good thing, maybe it's not. It's certainly a restriction, though, on new doctors. And also the discussion about no mentoring structure, no mentoring system in place for doctors that might be wanting to retire or slow down or whatever the case may be. And those are two things that kind of make me feel that recruitment, those are difficult situations to recruit under anytime you have restrictions like that. But in terms of there's 118 vacancies on the Health Authority website. We hear the statistic that we need 100 doctors a year for 10 years. What is the number of how many doctors do we need in Nova Scotia to kind of fill the void that's there right now, to kind of release the pressure from the pressure cooker and kind of make the system function more smoothly. It's not functioning smoothly right now. Do we have a number as to how many doctors we would need right now?
Ms. McCready-Williams?
Thank you for the question. We can just go to the data sources we have access to be able to answer that question. So we know, again, our shared plan would suggest we need 100 a year. There are 118 vacancies according to the NSHA's own site. And they're a combination of full-time, part-time, locum, and academic positions. So there's a variety there
Is the
of need right now.
118 the 100, or are they the same thing, or is it really 118 plus 100? Do you have any sense?
No, I don't have a sense of that. If Andre, do you?
Dr. Bernard?
I think we're talking, my understanding, the physician resource plan is a planning tool looking at a broader context over time, year on year on year on. So that's a snapshot of trends over time based on all the factors that are components of it. I think that needs to be set as something to use on the medium to long-term time horizon, in the context of which what I would say we're speaking of now are current needs that we know of specifically right now. And to return to Dr. Ms. McCready-Williams' notes, there is a composite need of family doctors, specialists, academic physicians to meet those current needs within the new Nova Scotia Health Authority to address current vacancies, which is to say, as we plan for tomorrow, next year, and the year after, we should expect that number will sustain as approximately 100 per year, as the physician resource plan is populated with new data that influence those trends. Nothing is static, and I guess that's the challenge of the context we're working in. We're trying to use as clear of an opaque crystal ball as we may have to predict what we may need, but we know certain truisms, which are complex care is becoming more and more clear. Doctors want to give the best care they can to their patients, and early career physicians want to practice collaboratively by and large. We can't say that all individuals would, but that's a trend we are seeing, and we need to find a way. We're running a relay race, but it's not just simply passing the baton from one physician to the next as we continue. The system is being rebuilt around us as we're running the race. And I think what we need to understand is how to create the preconditions to allow people to enter practices that address the health needs of Nova Scotia in a way that patients, and I'm a patient too, expect and deserve within their places. And I think we have our finger on how we can be collaborators with the Nova Scotia Health Authority and with government on how to do that. But certainly, if we take the snapshot of today, we see 118 vacancies. Well, regardless of the innovative strategies to address the broader concerns, we need to address those gaps.
Fix that. And in terms of the Canadians studying abroad, I do want to go back to that. Is there anything that we could be doing as a province right now to help bring some of those back? Like, is there any little policy, not little, but I mean, is there any obvious policy changes that we could make that would help entice them back? I guess, would that fall under the clinical assessment for practice program? If we had a functioning clinical assessment for practice program, would that help? Like, what?
I'll just, the issue of international medical graduates or Canadians studying abroad is a complex issue in that they're at a different stage of training. They're not necessarily Canadians studying abroad at medical schools in the Caribbean and in Ireland and Australia, among other countries, still need further training before their practice eligible period. So part of that is about residency training, both in family medicine and for specialty training. So in having this conversation, I think we have to be sensitive to the fact that there's that population of people. Also, there are physicians who are trained Canadians, Nova Scotians, who wish to enter the physician workforce, and that's where the cap really comes into play. So that's distinctly different. Whereas the international medical graduates are presenting themselves as they move through their training at a point in which they're practice ready. Okay. And I might turn to my colleagues for further comment.
Well, I do want to just, I only think I only have a couple minutes. I do want to ask about the Dr. Matheson arbitration. Are you familiar with the Dr. Matheson arbitration? Maybe somebody can just, it seems like maybe that arbitration identified a system-wide billing issue, and the health authority or the department is trying to say, well, no, that actually only impacted one physician and not the broader group. I don't know if Doctors Nova Scotia has looked at that arbitration decision and is the health authority kind of being heavy-handed on this? Is there something, am I missing something here? Or?
Ms. Patterson.
Thank you, Mr. Chair. I am familiar with Dr. Matheson's arbitration. Any arbitration on a billing matter does, in fact, technically, legally, affect one physician, but of course we can draw some conclusions more broadly, since other physicians are presumably billing similar codes in similar circumstances. That would be the case with Dr. Matheson's arbitration, I would say. Dr. Matheson's arbitration involved a billing rule that's quite complex, and I'm happy to explain it, but I don't want to eat into your time either. Sure. It involved a very complex billing rule, which has been improved a bit through better technology at MSI. It's not a health authority issue, I should say. It's really an MSI and Department of Health issue. I would say some of what affected Dr. Matheson's billings and the arbitrator's ruling has been addressed through better technology, so that physicians submitting their billings are now in a better position to comply with the rules as written than they were at the time of Dr. Matheson's arbitration. That's not a full and complete answer to all that the arbitrator covered.
No, it's helpful, actually. It is helpful. It is helpful. I think I do want to, I think my colleague touched on the mobility of doctors even with the province and the ability of a doctor to bring another doctor in to practice with them. And I think that's all being limited by the strategic plan of where doctors are needed. There is some kind of strategic plan that the department has or the health authority has of where doctors are needed. Is that a strategic plan that you would have had input into as to Doctors Nova Scotia? Like, are you hearing frustration from doctors about wanting to bring somebody into their practice but aren't being, it's a real issue, right?
Ms. Patterson, you just have about 20 seconds.
Thank you, Mr. Chair. Short answer would be yes, we certainly hear those frustrations, increasingly since the stand-up of the new health authority, which in part, I suspect, is about trying to develop processes on the fly on their part, and in part is a reflection of their new privileging process and procedures. But there's no question, I think it's fair to say, we hear from physicians often who are interested in beginning to think about retirement or in fact quite retirement ready and are struggling to bring in new physicians or to get approval to bring in new physicians and worry about the gap in patient care if they in fact follow through on their retirement plans. So yes, that's a very real concern.
Okay, thank you. Move to Mr. Wilson of the NDP Caucus.
Thank you, Mr. Chair. I know Steve McNeil and the Liberals promised a doctor for every Nova Scotian. That was their in their platform. That's what they've been saying for the last 3.5 years, and we know they've backed away from that. They haven't met they haven't fulfilled that promise to Nova Scotians. We know that collaborative centres. The center model is what they're talking about. So will the collaborative centers model meet the needs of Nova Scotians entirely and their access to a family physician and primary care clinicians?
Dr. Johnson.
It will meet the needs as it evolves. But it's a beginning strategy, and this has to be a long-term implementation. So there has to be a plan for now, a plan for 15 years from now, and some vision of how to get us there that takes into account the needs of patients and their communities and the physicians that are providing the care. And then that brings in all the how are you going to recruit people to this spot, how are you going to let them retire, and how are you going to organize this care appropriately. So it could, and it should, but it requires long-term strategy and planning.
Long-term strategy, and I think that's the transition I think the Premier is trying to make now in their commitment. They committed to Nova Scotians, a doctor for every Nova Scotian, a year after they would form government. And here we are almost 4 years into their mandate, and we've heard this from not only members of the Government Caucus, but the government, other organizations, that this is a long-term goal, and to make that type of commitment really is, I think, irresponsible, way to try to get yourself elected. You mentioned the need to attract 100 doctors a year for the next 10 years. Mm-hmm. Is there a plan in place to do that today?
Ms. McCready-Williams.
Thank you. I'm not sure if there is right now. What we know is that we know there's a number of vacancies. We know there are so physician recruiters are working very hard, and I know the health authority is working very hard to recruit physicians. I have no question about that. And I think because of the need, that if we have a more integrated strategy, we do it together, we might have a better outcome. So that's what we're recommending as part of our primary care paper, is that let's do this together, because we know what the need is. It's staring us in the face, and together I think we could accomplish much.
I appreciate that direct answer, that there's no plan in place now. Now that's, I would assume that's on top of, I mean, that's not even addressing the 118 vacancies that we have now. There was a commitment from the government to fund, I believe, 25 medical students per year. So we're pushing into the 4th year now. So we're looking at potentially 100 physicians. Are you aware if that's, were they able to meet that? And I know it would take a number of years before the province would benefit from that. But are you aware if that commitment was achieved over the last 3.5 years, going into the 4th year now?
Mr. Chapman.
So we've heard anecdotally, because the program isn't run through us, that there have been a number of physicians who've taken advantage of the program, but that the full program has not been exercised, I suppose.
Yeah. Because they, from what I heard, they do become members of Doctors Nova Scotia, right? So,
they do.
So there's another example of a commitment from the government that really hasn't transitioned into reality, and that concerns me. I know we heard earlier about some of the successes we've seen over the last number of years. Very proud to be part of a government to increase the residency seats for rural residency program down in the valley. There was mention of Dr. Ross and his report. There was mention of the collaborative emergency centers being open. There was mention of the mental health strategy, the first of our province. All those were introduced prior to this government. Could anybody in the panel direct me to a new initiative the current government has implemented that has made an important improvement to access of care here in Nova Scotia? I'm open to any suggestions.
Ms. McCready-Williams.
Certainly My Health NS, the personal health record, is an innovative tool, first of its kind in Canada. We were part of the steering committee that put that in place. So it's only in place in a limited form right now. There's 177 physicians who've signed up for that. But the opportunity presented by My Health NS is, we think, huge in terms of access, increasing access for patients, and for patients being able to take control of their own health, having their own health information, and playing a more proactive role in that. So I would point to My Health NS.
And I thank you for that, and I know that's important, but that is a long-term process, I believe, until you said 177 physicians. I mean, you represent over 3,000 physicians alone, and I'm concerned that the energy, the priority for the government has been the amalgamation of the district health authorities. You know, we've seen Dr. Ross's report, the collaborative emergency centers, the mental health strategy implemented all within 4 years and having a direct impact, a positive impact on the lives of Nova Scotians. And here we have government, you know, trying to go back to the polls to say, don't worry, we have healthcare in control. And I have to say, their major plan to amalgamate the district health authorities because it's going to solve all the problems in health actually has created more problems. So I'm going to try to go, I know my colleague talked about this a little bit around the federal transfers health agreement. That is not an agreement. We heard last week in public accounts was signed in December. The Premier in 2015 said that Nova Scotia has to sign a new agreement that included recognizing the aging demographics in our province. And we know now that that did not happen. And I think that was a huge mistake on our government's part to sign early without having that implemented. Are you hearing from your members, from family physicians, the challenges of having a practice dealing with that aging demographic? Are they finding challenges finding long-term care placements, for example? Because we know the current government hasn't opened one long-term care bed in 3.5 years. And so are your members, are the family physicians that you represent challenged when they're dealing with providing care to our aging population?
Mr. Chair, perhaps I could ask my colleague, Dr. Johnson, a family physician, to answer that question.
Dr. Johnson.
That's a daily challenge. The patients are complex. They require more time. They're inpatients, currently in acute care institutions, waiting to go to long-term care beds until we have a space open for them. It provides increasing complexity every day trying to figure out how to meet those needs appropriately. And it's frustrating. And then you have the patients within your practice that also need access to other allied healthcare professionals, diabetic educators, asthma educators. All of those things help us deliver care more effectively, and that's that team-based approach that we keep talking about when we talk about collaborative centers. Those things continue to be a challenge, and every day in every practice across the province.
Would anybody agree that the number of long-term care beds in our province is a concern? I mean, we know the domino effect when we have patients who are in our hospitals who need long-term care. I know there's an emphasis on home care. I'm fully supportive of that. But the decision to not implement and go forward with any new long-term care beds in this province has a devastating effect. We know Dr. Campbell at the QE2 ER talked about patients in the ER and patients in the hospital not being able to be placed in the appropriate place. So would you agree that is a huge challenge and was a mistake by the government not to look at increasing the number of long-term care beds in the province?
Dr. Bernard.
I will say from my perspective as someone who listens to the PA system at the QE2 every single day, and we heard the numbers, it's in the 20s or 30s, or 20s, I think, of the number of times you hear code census overhead, that issue is felt every single day of how we provide and address, how we provide care in the midst of the bottlenecks that exist in the system, of which comprehensive long-term care and home care need to be part of the solution. And I won't speak to the government's choices right now, but I would say that's an enduring problem. My father-in-law cut his finger last week or 2 weeks ago on a table saw, and he wondered what the crisis was when he heard overhead code census. I said, it's a crisis that happens nearly every single day, and we're seeing that in the news. You are hearing about that from your constituents. And part of that solution is addressing inefficiencies within the system and addressing bottlenecks that don't allow us to provide long-term care spaces and comprehensive community-based home care.
Are some of those deficiencies being addressed? Or do you feel that there are people listening, especially at the top level, the government, the Nova Scotia Health Authority, and you work daily in what we would call the trenches? Often those that are making the decisions are not in the trenches. Are you feeling that those concerns are being addressed as quickly as possible?
I think the answer to that question will always be no. But I say that in just a bit because we're not seeing it reduce in numbers. We're seeing it as a recurring theme. So I would say from the perspective of me looking after the patients I have to look after, and I don't just care about them or care for them when they're in my operating room that I work in collaboratively with my colleagues. We care about where they end up and where they get the best care possible and how they recover. So absolutely, we think solutions, I mean, I'm speaking on behalf of Doctors Nova Scotia, that we want the best for our patients, and we need to see a care continuum that's sensitive to the needs that we have right now, and yesterday was too late.
I know I only have a couple minutes, so I'll try to hopefully get a couple quick questions here. I know in your discussion paper, one of the recommendations was to continue with the walk-in clinics. I know that continuity of care is maybe compromised or not there when patients use walk-in clinics, but there's a great need in our province. So has the government acknowledged that or backed away from this notion that we need to close the walk-in clinics or change them into different types of service delivery?
Ms. McCready-Williams?
So I believe, certainly the conversations I've been part of, that they recognize that they fill a need while we're in transition to a new primary care model that will have greater access to care in communities as part of these collaborative care teams. But in the meantime, until we have that in place, they fill a need for non-emergency conditions, and they prevent those patients who are unable to see a family physician or a nurse practitioner, prevent them from going to an ER if that's not necessary. So to me, it's a transition piece, and that in a perfect world, the walk-in clinics would be aligned with the collaborative care centers and able to help with that provision of care after hours on weekends.
And you mentioned collaborative emergency centers. You supported them. Do you feel that there should be more in the province?
Yes, at the time we were supportive. We helped to roll those out, and they certainly brought stability to those communities where there were ER closures happening on a regular basis.
Thank you. We'll now move back to the Liberal caucus. Mr. Rankin.
Yes, just a couple quick questions, because you mentioned the 118 vacancies were planned retirements, so it's important that people understand that they're not vacant today. So of those 118 vacancies, how many of them are practicing today? Practicing doctors today?
I don't think I understand the question. Could you just please repeat
so
the
preamble? So you
preamble?
said there's 118 vacancies?
Yes, I'm just looking at what's on the NSHA's website. Yes.
Okay, so but some of those vacancies are practicing doctors today?
Yes, so according to the website, there's 52 GPs and 23 specialists who are full-time, 9 GPs and 1 specialist who are required on a part-time basis, 25 GPs and 1 specialist required on a locum basis, and 7 specialists in the academic center.
Yeah, so planned retirements, not retired today.
No, I don't know that you could make that assumption.
Okay.
So,
maybe you could clarify then if there's any of those vacancies that are practicing today.
Ms. Patterson?
Sure. Again, we're pulling this information from the Health Authority website, and so I think you may have misunderstood. If you thought Nancy had said earlier that though we believe some or many of those are planned retirements, we have no such knowledge. So we believe those to be primarily vacancies, actually, meaning practitioners who have left the province or retired, and there are vacancies left behind. We have no data to support that either. That would be our best guess.
Okay.
But not that they would be planned retirements, as in anticipated retirements.
Okay, because I know of some of my community that are planned retirements, but they're labeled as vacancies. So I just would like to try to flesh out a true normalized number. But and again, I'll just ask specifically, what is Doctors Nova Scotia doing to help recruit? What specific suggestions would you make to NSHA to help with recruitment? And the studies have shown that it's not just about compensation. So maybe you could just tell NSHA what you would like to suggest to help with recruitment for doctors in Nova Scotia.
do you want to take that, Ken?
Mr. Chapman?
So a couple of things. First off, and back to an earlier question, there are 2 ways we get physicians. We either train them through our medical school, and so one of the things would be to continue the work with DAL, and particularly, as Nancy said earlier, open up a new family medicine residency program. We actually need more anesthetists. So we actually need, while we concurrently recruit individual physicians, we need to train them as well, because that's basically the two paths in. So it would be the long-term goal of training our workforce, but also recruiting from other areas. In terms of recruiting from other areas, you're absolutely right. The payment model is whatever the payment model is today. We will negotiate in 2 years' time or whenever that works out. So the payments are whatever the payments are. So what we need to do is, and it's what Dr. Bernard said, we need to make a climate here that individuals want to come to. And there's a lot of things. So if you're going to go practice as a radiation oncologist in Sydney, you need a support system there so that you're not the only radiation oncologist and you're going to work 24/7, 365. You need supports through the, in this case, the QE2 Rad Onc department and perhaps colleagues. So supporting physicians, particularly in rural areas, is incredibly important. Mentorship programs are incredibly important. You mentioned you have physicians who are planning to retire. So I'll use Dr. Francis Moriarty, who's a lovely family physician in Dartmouth, wants to retire. It would be wonderful to have a family physician come in and work with Francis, where Dr. Moriarty would start to wind down. A family physician or two with Francis would start to take over that practice. And they would learn not only managing the patients, they would learn how to run that practice, the business side of it. Those are the intangibles that I think are really, really critically important. We met with the health authority last week, as Nancy talked about, to fill them in on what our health and dental plan, our maternity-paternity program. We were the first in the country to have a maternity-paternity program for physicians. Those are important recruitment tools. And then we're working actively with the health authority and with others to I don't want to say resurrect, but to create robust medical staff associations, because I think communities of physicians, whether you're at the QE2 or whether you're at Bridgewater, need support from their community and their colleagues, so that if you're a family physician on Main Street in Spring Hill, you're not in a solo, you're not out there by yourself, that you have a population of colleagues and physicians that you can turn to. So I think creating that medical staff association and creating that environment where a physician can come in with his or her family and be comfortable, accepted in the community, have supports, have colleagues. Those are the kinds of things I think we're looking to try and move forward.
Yeah, I would agree the support system's important, and I was happy to see in Digby the mayor come out and have all kinds of support systems in place for the new doctor's place there. And you mentioned the mentorship idea, which sounds great, like a lot of ideas do, but there's obviously a fiscal component that really needs to be looked at. Have you costed this out? What will this how will the impact be financially, and how will it get paid out, and do all doctors require this?
So great questions. So we haven't costed it out specifically, but what we have looked at is new physicians do not come in and bill the same way that a physician like Dr. Johnson might bill, who has practiced for 4 or 5 years, or perhaps longer. And so there is not necessarily a linear or even an exponential growth. So a physician who's winding down will start to wind down their practice, and a new physician coming in, we've looked at billing patterns, does not sort of hit the start mark on day one. So there is that natural transition in and transition out. There is clearly, if you have 2 physicians in a practice, there clearly is going to be an incremental cost, but it isn't an exponential or a linear increase. But you're paying for that in the guise of you're getting better access, because now you have 3 individuals or 2 individuals in a practice seeing those patients, and so you are improving access, and you're making an investment in the long-term sustainability of the system.
No, and I agree with the qualitative part. I was just wondering if you
so
had measured.
There is very good empirical data to suggest that new physicians don't bill sort of at 100% on day one, and physicians who are going to retire can wind down, and then there is a curve where they kind of match each other.
Okay, thank you.
Thank you, Mr. Rankin. We'll now move to Mr. Porter, and you have until 10:50.
Thank you, Mr. Chair. So I've got a few questions. I probably won't all get them in, but so I'll go through them quickly. There's been discussion around how, Mr. McCready, you supported and were part of the collaborative rollout. In your opinion, is it a good model?
Ms. McCready-Williams?
Collaborative model.
Just collaborative care generally speaking, yes, we support it. It's foundational in our position paper on primary care.
And to your knowledge, is this used in other parts of the country?
Yes, it is.
And would you deem it to be successful?
There's great evidence out there that it delivers really good patient outcomes. It's why we're endorsing it. Yeah.
So the patient outcomes is the part I wanted to get to. Obviously, you would see that there are improved outcomes, benefits. And also, to your knowledge, when did Nova Scotia start having problems with doctor shortages? Do you know what actions were taken to address it when the issue started? How long ago? This didn't start yesterday or last year or 2 years ago.
Certainly this has been an issue we see more of a discussion in the last couple of years.
My question was just to be clear.
Yeah.
When did it start? When did the issue of doctors and shortages start in Nova Scotia? And this was not an issue that just started and came to light in the last couple of years. So I'm just trying for some clarity here, if you can tell me from Doctors Nova Scotia perspective when that may have occurred.
Thank you, Mr. Chair. I think a number might have some insights on this, and so feel free to jump in. What I would say is this is an issue that ebbs and flows. And so in the past couple of years, we're experiencing a more pronounced issue around physician shortage than we had seen in the preceding period, certainly in the early mid-90s. We know it was quite prevalent as well. And I think there are various ebbs and flows people could point to. I think the experience of physicians in the province right now would be that we are currently experiencing a more pronounced physician shortage than at other times in history.
Dr. Bernard?
You know, I think any health system needs a tightly coupled health-human resources planning mechanism to address the changing context. And the context just isn't the underlying population health parameters, but it's everything. It's people moving in and out of the province. It's how we do practices. It's advances in medical care. And I almost chuckle to myself when you ask the question, because I would ask myself the question, has it always been this way from the very beginning? Because we're not in a state, this is not a static system. If we take ourselves back to how we practiced in the 80s, it's very different to how we practice today. And what care we provide our patients is constantly changing. So I think what we need to do is have an efficient planning tool that couples the needs in a way that addresses, and it's not just about the numbers of doctors, although that often is used as the composite for the underlying health needs. And that's what we've been talking about, is our support for collaborative care. It's about providing the best care possible for our patients collectively as Nova Scotians. And I think the mechanisms to do that, we have these data points or these markers in the channel that help us get to where we want to go. And I think what we would appreciate is we need to be faster and more attentive to the needs as they present themselves. So in the question, do we believe in comprehensive care, collaborative care? Absolutely. But I think what we would put forward, and has been put forward in our paper, is that it's not a one-size-fits-all solution. If you put in a one-size-fits-all solution, you won't address the variances that exist across this province. And I think most of us would agree to that.
Thank you. Time goes by quickly here. I want to ask a couple other questions. The My Health thing, the technology, we know that technology has changed so much over the years, especially in healthcare, by way of advances in the actual medicine to how we do business every day. I always find this technical piece interesting because it's always like living on the edge with changes. They're so quick. And it's about always being on the leading edge, it used to be said, and not on the bleeding edge of that sword. You know, where do we go? How do we go? But you can type, and I'll just use me, you can type my social insurance number in anywhere in this country and tell me all about Chuck, everything you want to know. When are we going to be at that point where I can type Chuck's health card number in, no matter where I am in this province, as an example? I'll start there. And this seems rather simple to me, a guy who's, you know, pretty simple, I guess. Really simple. I should be able to type it in Yarmouth, and you should be able to see everything about me, or in Glace Bay. It doesn't matter. Why is that going to take us so long? And I think it was mentioned that this is a long term. Why would this be so long? Technology's not, it's everywhere.
Ms. McCready-Williams?
Thank you. So one patient, one record, that initiative is incredibly important moving forward, so that healthcare providers, physicians, and others, nurse practitioners, can work together, sometimes virtually, sharing patient files. The fact that was sort of it was on then off, and now it's been resurrected by government, we're delighted with that. It's a platform in our primary care strategy to say that using technologies that are available to us, including One Patient, One Record and My Health NS, are critical moving forward.
Thank you, and I agree. There's a huge benefit to that, and I think it has a lot of benefits outside of what we're, you know, just the technology with regards to treatments and so on. The other piece you mentioned was around physicians, and I'll just think about my own physician. I've had her for years. Yes, it's a small business. It's exactly that. They are running their own business. Many may look at that as a very good business. She probably has 2,500 or 3,000 patients, and I'm guessing, but I would say something like that. She's been there for many years. Some might think that, wow, there's a chance to step right in and take over a business and be quite successful from a financial perspective, but I don't get the impression that that's something that's assessed maybe, or is that assessed along the way when we're in the recruiting mode? And yes, maybe one of the physicians would like to speak to that. Someone who does it every day, we can appreciate that. But I mean, it does seem like something that would be attractive, I guess, would be the right word or a better word, or enticing you to come with the opportunity to set right up in business, even if there was the mentorship piece, whatever that might be. Maybe your thoughts on that in my last 30 seconds or so here.
Dr. Johnson.
It sounds true. In theory, that would be great.
Okay.
I would argue that most of the people that are currently being trained in residency programs, so our new physicians, are not being trained in a system where they're seeing that many patients. So a practice that has 3,000 patients a day probably needs to generate 40 to 45 visits a day, which is very daunting to a new grad coming out who is used to spending 15 minutes with each patient and having time to address all of their complex issues. And as we age, and physicians' practices age with them, so their patients become more complex. And while I may know the in and out of the last 20 years of my patient, somebody who's new has all of that history to acquire. So it's very daunting and
how
not very
How many
efficient.
patients a day
Order.
would you...
I do apologize, but the time for questions has expired. Ms. McCready-Williams will give you an opportunity to provide some closing comments.
I certainly want to thank the members of the committee for the invitation to appear today, and all to say that physicians have some great ideas in terms of how to improve the system. They are key members of any collaborative care teams moving forward. They have some, in fact, they, you know, in terms of just their practice, the tests that they send patients for, the prescriptions that they write, they in fact control a lot of the costs in the system. So having them involved to help shape the future of the healthcare system in Nova Scotia is critically important. They as members of the association, come to the association and say, you know, can you please champion these causes on our collective behalf? And that's certainly our role. But so they have some great ideas. They want to be part of the solution, and they welcome an opportunity to work collaboratively, both with the Health Authority, with the IWK, and with the Department of Health and Wellness. So again, thank you for the opportunity to speak with you today.
And thank you for being with us. We appreciate your time and answering all of our questions. We do have some committee business. We had some correspondence received from the Department of Municipal Affairs that was requested from the March 22nd meeting. Are there any questions on that correspondence? Hearing none. We did have some outstanding communication between the committee and the Department of Transportation about the Cobequid Pass. Mr. Houston, I believe you had something that you wanted to provide in terms of clarifying the question asked for Department of Transportation.
Well, in fact, I think, Mr. Chair, we might have raised enough attention to the tolls in the Cobequid Pass that I think the minister just announced he's actually going to come clean and take them off. So maybe we'll just kind of close that one for now.
Okay, thank you, Mr. Houston. Our next meeting is scheduled for May 3rd, and the topic will be on school capital planning, which was Chapter 2 in the November 2016 report of the Auditor General. We have a briefing that morning from 8:30 to 9 and the full meeting from 9 to 11. There is a possibility that there is election talk in the air. This could be our last meeting. It may not be, but given there is some uncertainty around that, I just thought I would take the opportunity on behalf of the committee to thank those who provide us with support here for our committee business. I want to thank Legislative TV for the services they're providing. I want to thank our committee clerk's office, Kim Langell and Kim Ledley. I want to thank Hansard, Colleen Denome. I want to thank our Legislative Council, Nicole Arsenault and Gordon Hebb, and also the Auditor General's Office, Mr. Terry Spicer. Thank you, everyone, for your support. Again, our next meeting may be May 3rd, and we will now adjourn this meeting, and we will wait to see if there'll be any more. Thank you.